So, as usual, there are plenty of meta-analysis. So, this was a meta-analysis published last year, 2024, and they had 53 studies in which 2,400 gastric patients were involved. And again, what they found is that the proportion of patients with a regression in the peritoneal disease after HIPEC is 27%. Okay, so only a quarter of patients actually showed a radiological response, which is what we ask when we give chemo and radiation. So again, HIPEC doesn't cure everybody, it gives you a response of around 25%. And again in this study, the median overall survival is 16.4 months. So these are the numbers that we are really looking for if you do a HIPEC for patients with peritoneal disease. To be honest, it's like this, you are hunting for that little needle in that haystack to find the few patients who are likely to benefit. Unfortunately, if you actually go on the data, there are a lot of studies, analysis, reviews which keep talking of small studies of 20 patients, 40 patients and say that yes, everything is good. HIPEC and CRS are very good modalities. They are good modalities, but they are not absolutes. And of course, you have these one-off case reports by very eminent people who will tell you that people have survived for 25 years. So, I think Senthil sir is here, he will know, he will have patients who have survived for 25 years without any treatment. You know, you don't do anything, they may still survive, the one-odd patients. So, these are things which need to be taken with a big pinch of salt. Finally, what about the benefit of doing any aggressive surgeries in other sites? And this was a paper which has come last year, it is an abstract, we do not have the final paper. This was the Renaissance study, which actually was a phase 3 study, which randomized patients to surgery versus no surgery in patients with extra gastric metastatic disease, including RPLN or other areas. And they found that 20% with RPLN patients did have some benefit, but otherwise there was no benefit by doing a surgery in a frankly metastatic disease. So, unless patient has bleeding, obstruction or any such indication, doing a surgery is probably going to be of no use. So, finally, this is from the PSM group. So, you know, peritoneal surface malignancy group, which is very aggressive in promoting HIPEC and CRS, and even they have accepted that there is some benefit in selected patient, but overall not to be done in everybody. So, for me, first line therapy remains a chemotherapy that is either a doublet, very rarely a triplet. We would possibly not push for a triplet. We could include either pembrolizumab, nivolumab, or we could include a targeted therapy. This remains the first line of therapy. Anything beyond this is only to be done in selected cases based on MDT discussion. The Pan-Asian ESMO guidelines, which came out last year, recognize this fact. Along with the first line therapy, they have specifically mentioned that gastrectomy is not recommended in metastatic gastric cancer patients unless indicated for palliation. Now, because some resection cannot be recommended in general, might be considered an individualized approach with high volume disease. So, that is where the thing goes, and the same thing is shown in this study where they have shown the last bottom line. Patients who have a very good response for a long time, your systemic is working, you have limited disease, you would like to cure it, yes, surgery can be considered. How much would that be? For me, if the entire area is the metastasis peritoneal, small thing, possibly only those whom you pick up on surgery. You do a surgery, find 2 or 3 nodules here and there which can be resected, possibly that is the patient where it will be still worth it. Otherwise, if you have a low PCI, maybe less than 6, maybe stretching it a bit, then systemic therapy with a planned surgery can be thought of. Very good response to treatment, long survival, and there is a limited disease, maybe after 10 months, 12 months, possibly yes, you could consider it, but everyone else, the treatment remains only systemic therapy. So, take home messages from my side is that systemic therapy is the choice, immuno plus chemo plus targeted wherever applicable. If there is gross peritoneal, there are no RCTs, negative studies, I would not advise it. Limited, discovered at lab, probably completely resectable, it is an option, though there is no evidence. Probably the role of HIPEC CRS is there in this group, which patients have a good response, long PFS and limited disease. So, that would be my takeaway. So, thank you very much.